Yeah, I'm just going to start since I know we have to get to Somerset for EPIC training. Good morning, everyone. My name is Anna Green. I'm one of the PGY3s. I'm going to be presenting this morning on Lisfranc injuries with a focus on open reduction internal fixation versus primary arthrodesis as a part of foot and ankle grand rounds. These are my objectives. And an overview, we'll just start with some cases and then I'll go into the background, talk about the literature, focusing again on open reduction internal fixation versus primary fusion, and then end with case conclusions and hopefully a good discussion. All right, so moving to the first case, this is JB. He's a 29-year-old gentleman, trauma that we are called to the trauma bay for after a motor vehicle accident. These are the spot shot films that they have before they call us, and they call you with just some sort of left open foot and ankle injury. Do any of the medical students or interns, juniors want to just shout out what they see, what their concerns are, and what you're going to do when you go evaluate this patient? Awesome. Yeah. So on like I said, these are just the spot shots, so you don't have a lot of information, but immediately you're drawn to the left foot on the left image, and you can see that there's overall loss of alignment of the metatarsals. You can see that there seems to be some sort of comminuted fracture dislocation at the second and third metatarsal bases. And then obviously on the right side, you're concerned about an open injury. There appears to be some sort of complex pilon or ankle fracture dislocation. So, concerns that we're worried about, obviously it's an open injury. So you want to make sure you give ANSEF or antibiotics and tetanus. With a complex injury like this in the foot, you'd be worried about compartment syndrome, especially at a high energy mechanism. So you want to make sure you get a good neurovascular exam. So these are the things that you want to be looking out for when you're just arriving on scene. So this patient is taken pretty emergently. It happened in the middle of the night, so it was just a few hours. He was shortly taken for an IND and X-fix of the ankle. These are the X-rays of the foot. As you can see, it's still not a complete foot X-ray series, probably limited by the fact that he has an X-fix on. You can still see again on the AP of the foot, there seems to be some disruption of the Lisfranc midfoot joint. And then on the lateral, you can see some subluxation of the TMT joints as well. So this person is inevitably taken to CT for better delineation of his midfoot injuries. I'll scroll through this CT. So going through the axials, you can start to see the navicular fracture that looks fairly non-displaced. And then you'll go into the midfoot and see a pretty comminuted middle and lateral cuneiform fractures, as well as base of the second and third metatarsal fractures, and kind of a non-displaced base of the fourth metatarsal fracture. I think the axial shows it best. I'll just play the other series as well. Again, you saw the navicular, and then going into the cuneiforms, showing significant comminution as well as base of the metatarsals. And then on the sagittal, you can see subluxation of the TMT joints. Does anybody have any initial thoughts on how they would want to manage this patient? Just knowing that there's, this comminuted complex midfoot fracture. He's young. It was high energy. What do you want to do now that he's in an X-fix? We can just go into the other cases too, and then we can kind of talk about them all together. Fusion, yeah, it's a good option. Would anybody open reduce it and just internally fixate it? Potentially, okay, good. Good, yeah, he's young. Absolutely. Yeah, definitely. There's a lot of comminution. So these are all things that I will circle back at the end for a better discussion, and hopefully with some of the information we present later, maybe some opinions will be changed. Going on to the second case, this is AB. This is a 40-year-old female. who is also presenting after a motor vehicle collision, and she's just complaining of a lot of persistent foot pain. The x-rays were originally read as within normal limits, so I don't believe orthopedics was originally called to assess this patient. However, she's unable to bear weight, and she's very swollen and tender. Eventually, they sent her for a CT of her foot 2 days after her initial injury. Scrolling through to the metatarsal bases, you'll start to see this periarticular fracture pattern around the base of the second, third, and fourth metatarsals. Fairly non-displaced. And then going through the coronal, you can see the base of the metatarsal fractures as well. And then sagittal, not showing any significant subluxation, maybe a little bit. And then just a short fast forward. So she has this midfoot fracture, periarticular, base of the metatarsals. This is her intraoperative stress, showing pretty significant instability of the entire midfoot, where there's near 100% dislocation of the, particularly the medial 3 joints. So pretty unstable despite x-rays initially being read as negative.
Where's the motion?
I mean, I didn't meet this patient. I doubt it though, just based off of the instability of her exam intraoperatively. And it seems like she was unable to bear weight, and that's why they proceeded to get the CAT scan and then call for an evaluation from us.
Is the instability at the joint or at the fracture?
Yeah, also a confounding factor.
What do you mean when you just showed us?
The next patient is another young patient. This is an 18-year-old male lacrosse player who, after a sporting injury, is presenting to the office, I believe, just complaining of significant right foot pain that's been persistent. On his x-rays, overall, unlike the first patient who had this, very obvious franc midfoot fracture dislocation, his films don't really look that remarkable, but he is presenting with pretty significant pain. He's then in the office, he is indicated for some weight-bearing films, left and right to compare. So looking at the left foot, which is his normal foot, there's no pain. And then you can look at the right foot, and you can see some widening of the medial column there, indicative of a midfoot injury. And then the fourth and final case, before I go into the rest of the topic today, is DT. This is a 61-year-old lady who fell from pretty much ground level. It sounds like she tripped on something and fell backwards. And she was presenting with pretty significant left foot pain after her fall. And her x-rays, again, don't look super exciting. Just looking at the films, AP, oblique, and lateral, no major fracture dislocations or subluxations. And so she is also, some weight-bearing films are taken in the office, comparing her left foot, which is the symptomatic one again, and then her right foot. And you can again see some widening between the first and second metatarsals compared to her right foot. And then again on the weight-bearing laterals, the top being just resting and then the bottom one being her weight-bearing lateral, you can potentially see some naviculo-cuneiform subluxation dorsally. So she also has a CT available. So going through her axials, you can start to see some base of the metatarsal fractures. There's the cuneiform fracture. Overall non-displaced. And again, on her coronals, and sagittals. So overall, I'd just like to open the floor if anyone has any ideas, initial ideas on how we can manage each of these patients. We have case one, who's the young gentleman who had the high energy trauma MVC, who had a left open ankle fracture, as well as a comminuted fracture dislocation of the midfoot. That was also open. Their second case, who was the 40-year-old lady who was involved in a motor vehicle accident and had the non-displaced periarticular fracture dislocation of the TMT joint with a pretty significant abduction, stress positive fluoroscopy. The young lacrosse player after a sporting injury who had the weight-bearing stress positive exam. And then the last case, who was the older lady, 60-year-old, who had a trip and fall from ground level and had a left foot stress positive evaluation. Is there anybody who would either fuse all, fix all, combination? So you'd still consider fusing the younger kid just because of the combination. It's a good thought. All right, so we'll go back to these and open it up again after we talk about some of the literature and background. So Lisfranc is a French Napoleon era surgeon who first described the injury in about 1815 after he did an amputation at this joint. The Lisfranc injury refers to an injury where one or more of the metatarsals are displaced from the tarsal bones. The term is more commonly used to describe an injury to the midfoot centered on the second tarsometatarsal joint. And Lisfranc injuries really encompass a really broad spectrum of injuries, which can be purely ligamentous or complex fracture dislocations, like the first patient we talked about, involving the osseous and articular structures. They're often difficult to diagnose and treat, but if they're not detected and appropriately managed, they can cause significant long-term disability. It's estimated that 20% of these injuries are missed at their initial presentation, probably because a lot of them occur after these high energy mechanisms where there's a lot of other distracting injuries. But these injuries are more common in men in their 30s. Just to talk about some of the anatomy, starting with the osseous stability. The Lisfranc or TMT joint is formed by 3 cuneiforms and the cuboid proximally, and then the 5 metatarsals distally. It's commonly described in 3 columns, where the lateral column consists of the articulation between the cuboid and the 4th and 5th metatarsals. The middle column is made up of the 2nd and 3rd metatarsals, articulating with the middle and lateral cuneiforms. And then the medial column, which is made up of the medial cuneiform and the 1st metatarsal. These 3 columns are incorporated in both the longitudinal and transverse arches of the foot that provide the bony stability of the Lisfranc joint. The transverse arch provides the main bony stability. When viewed in cross-section, the structure appears similar to a Roman arch as pictured in the bottom left image. This is an inherently stable configuration. In the coronal plane, however, the proximal end of the 2nd metatarsal is also recessed between the medial and lateral cuneiform bones, as seen in the bottom right image, creating a mortise and providing additional stability. A biomechanical study of this mortise joint compared the depth of the mortise in patients with Lisfranc injuries and compared that to that of the uninjured subjects. And they found that shorter length of the 2nd metatarsal, as well as decreased depth of the 2nd TMT mortise, have been identified as risk factors for these Lisfranc injuries. The stability of the Lisfranc joint is further maintained by ligamentous structures. The ligament structures are divided into plantar, dorsal, and interosseous components. The plantar and dorsal ligaments have longitudinal, oblique, and transverse fibers. The longitudinal and oblique fibers connect the tarsal bones to the proximal metatarsals, where the transverse fibers connect the metatarsals proximally. Generally, the plantar ligaments are stronger than the dorsal ligaments, which is why dislocations are often in the dorsal direction. And then additionally, there's the intermetatarsal interosseous ligaments, which are the strongest of all of these ligament attachments associated with the Lisfranc joint. However, there's no intermetatarsal interosseous ligament between the 1st and 2nd metatarsal bases. Instead, the base of the 2nd metatarsal is connected to the 2nd metatarsal to medial cuneiform by the Lisfranc ligament. And this is the largest and the strongest of the interosseous ligaments. Several other important anatomic structures are surrounding the Lisfranc joint, namely the dorsalis pedis artery and the deep perineal nerve, which cross the Lisfranc joint dorsally between the base of the first and second metatarsals. Concomitant injuries to this nerve and artery have been described with Lisfranc fracture dislocations. So it's really important to do a careful physical examination when assessing these patients. It's also important to consider the normal motion at each of these joints. There's overall pretty little sagittal motion through the second tarsal metatarsal joint and only about 3 to 5 degrees in the medial column. The fourth and fifth metatarsal joints have greater sagittal motion, about 10 degrees of flexion and extension, which is clinically significant for 2 reasons. First, it is this mobility that allows individuals to mobilize on uneven terrain. And secondly, this mobility is thought to be the reason that instability within the lateral column can be tolerated without the development of symptomatic lateral column arthritis. The rigidity of the medial and middle columns is clinically significant as it allows the foot to function effectively as a lever arm during normal gait. And it also experiences the largest force during the heel rise phase of gait. Excuse me. In addition, the plantar ligaments are the major stabilizers of the Lisfranc joint in the on-point position in ballet dancers. These strong ligaments and proper ballet shoes are really important to help prevent Lisfranc injuries and metatarsal injuries in ballet dancers. So overall, although many of these injuries are initially missed, they can have severe consequences if they're left untreated. They can result in painful post-traumatic arthritis and arch collapse. So the prompt diagnosis and maintenance of the anatomic reduction of these joints are necessary to maximize patient function and outcomes. So on presentation, overall the mechanism, injury can come from direct or indirect mechanisms. An indirect mechanism is usually more common, and that's from axial loading or twisting on a plantar flexed foot. This is commonly from motor vehicle accidents like our first 2 patients and falls from significant height. Direct Lisfranc injuries, although less common, do occur and happens from when a direct load is applied to the Lisfranc joint, such as a crush injury or direct blow. The primary symptoms are pain and inability to bear weight. They can have significant foot swelling and often present with plantar ecchymosis. Like we talked about before, compartment syndrome is a potentially serious complication that may occur in patients with these major foot traumas, including the Lisfranc fracture dislocations, in which case emergent fasciotomy should be performed. So overall on diagnosis, the initial evaluation of these injuries is done with plain radiographs. Normal X-ray studies of the foot consist of AP, 30-degree, oblique, and lateral views. And it's really important to understand the normal anatomy of the foot when you're assessing these radiographs. In a normal foot, the AP radiograph shows the medial border of the second metatarsal and the middle cuneiform aligned. On the oblique view, the medial border of the fourth metatarsal and the cuboid should align, as well as the medial navicular and medial cuneiform. On the lateral view, the superior border of the metatarsal base should be aligned with the superior border of the medial cuneiform. Markers of instability include widening of about 2 millimeters or greater between the first metatarsal medial cuneiform axis compared to the second metatarsal, especially when you compare that to the contralateral side, 2 millimeters of joint subluxation of the TMT joint or any dorsal displacement of the metatarsal on the lateral view. The most common radiographic finding in a Lisfranc injury is diastasis of the base of the first and second metatarsals. However, it has been shown that in up to 50% of patients, non-weight-bearing radiographs were normal and missed the diastasis between the first and second metatarsals. A radiographic finding pathognomonic of a Lisfranc injury is the flex sign. This is a bony flex seen in the space between the first and second metatarsal bases that represents an avulsion at the attachment of the Lisfranc ligament from the second metatarsal base. And it is present in approximately 90% of cases. With more subtle Lisfranc injuries, such as purely ligamentous sprains, weight-bearing views and comparison views are crucial to help in diagnosis. We can also do pronation abduction stress views, such as the second case, which was done intraoperatively. However, this may not be tolerated by an acutely injured patient. If you do suspect a Lisfranc injury in a patient, CT or MRI may show occult fractures and dislocations. Cadaver studies have shown that MRI and CT can show occult fractures and dislocations and are more sensitive than plain radiographs for detecting minor amounts of displacement in these joints. So this is an X-ray just showing the normal configuration that you're looking for on the AP, where the medial border of the second cuneiform and the middle cuneiform align. And then similarly on the oblique, you're looking for the alignment of the medial border of the fourth metatarsal and the cuboid. The most common classification used to describe these Lisfranc injuries is the Myerson Classification scheme, which divides injuries in terms of joint congruity, the location of involvement, and the direction of instability. Type A injuries have total joint incongruity. Type B injuries are further subdivided into 1 and 2, where B1 injuries involve the medial column in isolation, and then B2 involve the lateral raise. Type C injuries represent divergent patterns, either partial or total. And although this classification system does not predict outcome, it does provide a framework for understanding these patterns. In 2002, Nunley and Vertio described a classification system for the use of more subtle, low energy Lisfranc injuries, primarily in athletes, that would also aid in clinical management. This classification system was the first to clearly relate stages of injury to the treatment methods. Patients in stage 1 in the upper left were not able to bear weight or participate in their sport. They had pain at the region of the Lisfranc ligament complex, and the injury was mostly non-displaced on weight-bearing radiographs, so stress negative. Patients with stage 2 injuries had a first to second metatarsal bone diastasis of between 1 and 5 millimeters on their AP weight-bearing radiographs, but no evidence of loss of their midfoot arch on the lateral weight-bearing radiograph. And then finally, patients in stage 3 had first to second metatarsal diastasis of greater than 5 millimeters on AP weight-bearing radiographs, with loss of midfoot arch evidenced by the decreased distance between the fifth metatarsal and medial cuneiform on the lateral weight-bearing radiograph. Overall, patients in stage 1 were managed non-operatively in a cast, whereas patients with stage 2 or 3 injuries were managed with either closed or open reduction and internal fixation. Overall, the goal of treatment is to restore the functional anatomy of the foot. Definitive management is often delayed until soft tissues allow and are appropriate for open approaches. And the further delineation of the pattern of instability is delineated. In general, rigid fixation is used to recreate the stability of the medial and middle columns, whereas the lateral column flexibility is important, like I discussed earlier, to allow weight bearing on uneven surfaces. Overall, these injuries are almost always operative. Non-operative management has a very limited role and has really only been used in completely stable injuries that are stress negative and where there's really just injury seen on the MRI. To the Lisfranc ligament, current recommendations emphasize more stable fixation after open reduction, with screw fixation of the medial and middle columns providing greater biomechanical stability than pinning alone. And the lateral column can be stabilized with pins because this allows motion that's normal in the lateral column. Some important factors to consider when you're deciding what treatment option might be best for your patient include the initial radiograph evaluations, advanced imaging such as CAT scan, the mechanism or energy involved, which gives you an idea of the integrity of the ligaments within the foot. And then also your intraoperative assessment is crucial, including any instability on stress abduction and the integrity of the articular surfaces when you look at them. So overall, I just want to talk about in a more detail the open reduction internal fixation versus primary arthrodesis debate. Overall, there's really no conclusive and agreed upon optimal treatment for these injuries. There's two major groups of surgical interventions available for the treatment of these injuries, either ORIF versus primary arthrodesis to fix or fuse. Because there's a wide spectrum of severity of instability patterns and concomitant joint conditions, there's really been no concrete evidence to support any particular treatment modality. Traditional surgical treatment consisted of open reduction internal fixation, but some surgeons, particularly lately, have advocated for primary fusion. Even within these broad groups, there's some debate into the types of fixation utilized, for example, using screws or plates, which I'll talk about a little bit towards the end. So this was one of the first more recent landmark studies that indicated ligamentous injuries may be treated better with primary fusion. This was by Dr. Kuo in 2000, published in JBJS, and it looked at the outcome of open reduction internal fixation using transarticular screws. They did a retrospective study of 48 patients and looked at their outcome scores at an average of 52 months postoperatively. Their average AOFAS midfoot score of patients undergoing open reduction was only 77 points, with higher points indicating a better outcome. Patients lost points for mild pain, decreased recreational function, and the need to wear an orthotic in their shoe. Patients with a non-anatomic reduction were significantly more likely to subsequently develop radiographic signs of arthritis. 12 patients, which comprised 25% of the patient cohort, went on to develop post-traumatic arthritis, and 6 of those 12 underwent arthrodesis at around 12 months from their initial surgery. And if you look at the table, their outcome scores were much worse when they ultimately went from open reduction to internal fixation and then subsequently to primary fusion. And they also found that patients with purely ligamentous injuries had worse outcomes overall, which led them to believe that open reduction internal fixation may not be the best and optimal treatment for these types of Lisfranc injuries. So overall, their conclusions from this paper, they concluded that anatomic reduction was really crucial to have the best outcome in their patients. And even with immediate fixation, there's a high rate of chronic midfoot and post-traumatic arthritis that required subsequent procedure. Another pretty impactful level 1 study occurred in 2006, also published in JBJS by Lee and Coetzee at the University of Minnesota. This was a prospective randomized study comparing open reduction internal fixation with fusion in purely ligamentous Lisfranc injuries. They included people with just a flex sign as purely ligamentous. And these were primarily in high energy injuries, mostly motor vehicle accidents and falls from height. There were only a handful of sporting injuries and ground level fall injuries. 20 patients were treated with open reduction and screw fixation, and 21 patients were treated with primary fusion of the medial second and third rays. Anatomic initial reduction was obtained in 18 of the 20 patients in the ORIF group and 20 out of 21 in the Arthrodesis group. At 2 years postoperatively, the mean AOFAS midfoot score was significantly lower in the open reduction internal fixation group at 68.6 points compared to 88 points in the primary fusion group. 5 patients in the open reduction group had persistent pain with development of deformity or osteoarthritis, and they were eventually treated with arthrodesis at an average of 35 months later. The patients who had been treated with a primary arthrodesis estimated that their post-operative level of activity was 92% of their pre-injury level, which is pretty high, whereas the open reduction group estimated that their post-operative level was only 65% of their preoperative level. So their conclusion was that a primary stable arthrodesis of the medial 2 or 3 rays appeared to have better short and medium-term outcomes compared to open reduction and internal fixation of these primarily ligamentous Lisfranc injuries. In 2009, Henning et al. From Michigan similarly performed a prospective randomized study comparing functional outcomes and subsequent surgeries in the open reduction internal fixation versus primary fusion patients, another level 1 study. The outcomes measured included the short form 36 and short musculoskeletal functional analysis, or SMFA scores, which showed no significant differences between the open reduction versus internal fixation versus primary fusion group at up to a year, which is fairly short term. There were significantly greater number of open reduction internal fixation patients returning to the OR, however. For the open reduction internal fixation group, it's important to note that their study design was built into their protocol to remove the hardware at 3 to 4 months prior to advancing their weight-bearing status. 3 patients refused to return to the OR for hardware removal as they were asymptomatic, which left 79% undergoing a subsequent surgery in the open reduction internal fixation group. And only one patient also went to secondary fusion due to persistent pain. In contrast, there was a really high fusion rate, 94% in the primary arthrodesis group. 3 patients in the primary arthrodesis group underwent a secondary surgery, 1 for symptomatic hardware and 2 for, they just wanted it as per their request. Overall, they found no significant difference in this study in the functional outcomes at 1 year. Although the remark on the significant return to OR for the open reduction internal fixation group, like I said, their study design does not really fairly assess the return to OR, as all of the open reduction internal fixation group, they plan to take them back to the OR. One of the major pitfalls of these past few studies is that there's relatively short follow-up. In 2016, another JBJS article by Dubois from Switzerland assessed clinical outcomes, the occurrence of symptomatic post-traumatic arthritis and risk factors for symptomatic post-traumatic arthritis between 2 and 24 years post-operatively among patients with Lisfranc injuries treated surgically, including open reduction internal fixation and primary arthrodesis. This was a retrospective study of 50 patients in the ORIF group versus 11 patients in the primary fusion group, and they looked at them at an average of 10.9 years later. At the time, their protocol was essentially to fuse if open reduction internal fixation was not possible based on the amount of comminution. So patients who underwent open reduction internal fixation typically had a hardware removal at 4 months. The outcomes measured included the AOFAS score, foot function index, where higher scores indicate more disability, the visual analog scale for pain, and the short form 12 score. At final follow-up, functional outcome scores were really not significantly different between these groups. However, they did find an overall high rate of radiographic arthritis, with 50% of patients being symptomatic, which was associated with lower functional scores. However, only 4 patients ultimately underwent salvage arthrodesis. So overall, the study found that functional outcomes were pretty similar between the 2 groups. The next study I wanted to present was in 2017 by Chow et al. This was a small retrospective study comparing open reduction internal fixation and fusion. All fractures healed for both groups. Patients in the arthrodesis group, however, had a higher AOFAS score compared with patients in the open reduction internal fixation group, 94 versus 88 points as seen in the table. Complications occurred in 8 patients in the non-arthrodesis group versus only 2 patients in the arthrodesis group. Their overall conclusion was that primary arthrodesis had better and more advantages compared to primary open reduction and internal fixation. There are fewer complications, higher AOFAS scores, and fewer frequent and better anatomic alignment. Currently, really, fixation remains the standard of care in the young athletic population. However, because the young athlete is higher demand, maintenance of motion in the medial column is thought to be necessary to restore the full function. Besides limitations to motion, the higher demand athlete with fusion may be at risk for pseudoarthrosis, stress fractures, and development of transverse metatarsalgia. However, Cochran et al. Presented evidence that kind of challenged this idea. They compared active duty military personnel with low energy Lisfranc injuries, which were primarily ligamentous, where 14 patients were treated with fusion and 18 were treated with internal fixation. The primary fusion patients had an earlier return to full military activity and better fitness scores after 1 year. The primary fusion group returned at about 4.5 months, whereas the open reduction internal fixation group returned at an average of 6.7 months. And they also looked at their fitness scoring, where primary fusion group ran their fitness tests at an average of 9 seconds slower compared to their preoperative level, and the open reduction internal fixation ran it significantly slower at 39 seconds slower per mile than their preoperative level. There were no differences between the 2 groups in terms of their foot and ankle ability measure or FAAM scores. And they did find that there was a higher implant removal in the open reduction internal fixation group. Their major conclusion was that these low energy Lisfranc injuries treated with primary fusion had a lower implant removal rate, an earlier return to full military activity, and better fitness scores after 1 year, but no difference in their outcome scores at 3 years. A big limitation of this study was that there was really no randomization. More acute injuries were treated with open reduction internal fixation. And for these more subacute injuries, they tended to just fuse them. And most of these injuries were purely ligamentous, like I mentioned. Buddha et al. In 2018 sought to further investigate reoperation rates as well between open reduction, internal fixation, and fusion groups, and found no difference. When excluding planned removal of hardware, patients with Lisfranc injuries treated with open reduction, internal fixation did not demonstrate a higher rate of reoperation compared to those undergoing primary arthrodesis. Adult patients who sustained closed isolated Lisfranc injuries with or without fractures and who underwent open reduction or primary fusion with minimal follow-up of 12 months was analyzed. Again, pretty short follow-up. They looked at 163 patients who underwent open reduction internal fixation and 54 patients who underwent primary arthrodesis. Overall, and including planned procedures, patients treated with open reduction internal fixation had higher rate of return to OR compared to those with primary fusion. However, when you exclude all the planned removals, there was really no significant difference. More recently, there really haven't been any high-level evidence studies. They're mostly just meta-analyses and systematic reviews. Most recently, in 2020, this was a meta-analysis of some of the studies that I had already talked about, which compared the outcomes and found no difference in functional outcome, but a higher rate of hardware removal in the open reduction internal fixation group when you're comparing with primary fusion. So overall, there's really just a lot of conflicting evidence based on few low-level studies that we have to base all of our clinical decision-making on. I just wanted to touch briefly on this topic. Traditionally, internal fixation was done using multiple transarticular screws, which allowed for reduction and presumably ligament repair. However, there's a theoretical risk of iatrogenic injury to the articular surfaces. Alternatively, dorsal plating has been proposed in order to minimize the articular damage. Plates don't cause joint damage, but they may require a wider surgical exposure and can increase soft tissue irritation. However, these factors really haven't manifested in reality. No differences in functional outcomes have been linked to the type of implant. Most studies have concluded that anatomic reduction is the most crucial factor in predicting the functional outcomes. This was a single retrospective study that is often cited in the literature where AOFA scores were significantly better in the bridge plating group compared to transarticular screws. However, in this study, the plate fixation group was noted to be trending towards a better anatomic reduction in general. So it's often recommended just in general that the locking screws be used distally and proximal holes. The distal and proximal holes and non-locking screws be used closer to the joint so that you can direct it away from the joint. But overall, there really hasn't been any conclusive evidence to support one or the other. I also wanted to mention this. Recently, suture button fixation has been considered as an alternative to the traditional home run screw of the Lisfranc ligament. The advantage of the suture button is theoretically maintenance of midfoot flexibility, while similarly providing stability. This was a 2009 JBJS article by Panchvavi in Texas that found that there was equal biomechanical stability comparing transarticular screws and suture button fixation, but really further studies need to be done to show that there's equivalent outcomes for patients. So now I'd like to just go back to our cases and hopefully with all of the information, probably information overload that I just presented, we can have a discussion or debate on how we can treat these patients. There probably really isn't one correct answer. So going back to JB, the 29-year-old male, he's the trauma, high energy MVC with the open ankle fracture dislocation, as well as the open comminuted midfoot fracture dislocation. Does anybody have changed their ideas or thoughts or opinions on how we should treat this guy? No. So everyone wants to fuse him. He's 29. No one wants to fix him. Dr. Fleming wants to fix him. Okay. Does anybody want to support what their decision is?
Are you expecting to come back 15 years later? What's going to happen?
Some level of arthritis, but I, as amateur in that study, I think it's pretty true. Radiographic arthritis doesn't always consider bad arthritis. So you can see patients that have bad X-rays that they're doing well. So, I think probably earlier in my career, I could listen to the bone graft and used it. Stabilize some of these patients. But this is a different issue. This is segmental. It involves a lot of things. The intermediate pops up. So there's no right or wrong. See how they do.
Take that hardware out.
The majority of the time,
Since you're not using
some of it, yes. So anything that crosses the navicular sapphire that joint, that part of it breaks. So I'll use lock screws in the hopes that essentially the locking portion of the screw will stay engaged with the plate. The screw fails and will run out. So basically the screw doesn't pop closely. It's engaged with the locking. So you can avoid. That allows motion. It's like having broken spies. It's the same concept. The screws stay in, they're broken, but they allow the ceiling and now you get this kind of control. But, so NC joint usually comes out, and then the first parts of the first part screw out. Outside of that, those joints don't. Second and third joints have 0.6 millimeters. So it's a stable joint.
So as you would imagine, this person put on broken erection internal fixation. For those exact reasons, it just seemed like a big hit to use, everything at once in such a young guy. So the second patient, 40-year-old lady, motor vehicle accident, high energy mechanism, no initial major fracture dislocation seen. Probably more significantly, she had a very grossly positive abduction stress test intraoperatively. What do you want to do with that? Not up. She's 40. Not really that old. Use or fix. A little bit of both. Does anybody want to support their opinion? So she ultimately underwent primary fusion, and the reason being that she had just gross instability intraoperatively. I mentioned before that there's a lot of different factors going into how to decide what to do, and one of them was intraoperatively what your stability is. Even though she didn't really have any major fracture dislocation on her plain x-rays, it's pretty apparent on her stress test that she's just completely grossly unstable. So it's thought that it's better to use her.
And what's exactly fused there?
So she's fused in the medial and middle columns. The lateral column is just pinned, which allows for, a little bit of instability, which is not instability, but it allows for some flexibility in the motion at those joints. And those were pulled, but her entire first, second, and third to the medial and middle cuneiforms are fused.
And the medial.
Yes, and the medial and the middle cuneiforms are fused together.
I just want to jump in here, and I don't take care of feet, but I'm trying to extrapolate some of the principles to what I do in the hand here, and I guess that my question, because it looks like.
So does that come out, or is that just,
There's no motion. Simply because
there's no motion? That's what I just wasn't sure.
There are hard joints that use with only a small amount of cartilage. I think that just got to be the before. That's only the top. Oftentimes, it's into some of the time. And some tend to isolate it to the Lisfranc joint that's oftentimes there.
And then just for follow-up sake, these are 2-year follow-ups. This injury happened a couple years ago. She's had pretty well-maintained alignment.
One thing that I want to realize that an ankle it's something but we don't really talk about that. So, arthritis, adjacent joints. But she's 2 years follow-up, and she's got some that do so you can get to consider that as well. Just on the pattern. She was not symptomatic. If you look at the sagittal line motion, I'm says that's at a 50%. Lock up the target back.
Yeah.
Oh, sorry. Oh, it's this. Can someone try to talk real quick?
Anna, can you hear me?
Oh, yeah, sorry, thank you. Yeah, I can hear you.
Okay, all right. I started to make a comment, and I think Dr. Kirschenbaum wants to follow me. But my comment here is, and then I don't take care of feet. I'm extrapolating from some of the stuff I do in the hand. But it looks to me like your anatomic alignment was okay with this case, but it was purely a ligamentous injury. And maybe there were some small, minute fractures, but not articular incongruity. So my question to you is, do these ligaments heal? And maybe that's why the people that are ORIF don't do as well as the arthrodesis, because the ligaments actually don't provide enough stability. And their pain and discomfort, functional limitation is all because of micro instability as opposed to osteoarthritis. I imagine osteoarthritis is going to take, a period of time before it sets in. And again, when you talked about that Lisfranc being, more important on the plantar side, typically you approach these dorsally. So maybe we're just missing it here, and the bailout is the arthrodesis. But if we augment the ligament or reconstruct it you know, these people can have, you know, the best of both worlds where they keep that little bit of motion, they're functional, and they don't need such an invasive procedure. So in conclusion, could you have just put a couple pins in this one and let it heal? Or do you think that the ligamentous structural support wouldn't be enough?
I'm sorry, so I understood the first part of your question. So to answer that, I don't think that pins would necessarily adequately control the stability of the first and second columns for it to heal. I think pinning would be similar to just open reducing and internal fixation, and it wouldn't really provide enough stability, especially in someone grossly unstable like this on the stress exam. And I didn't understand the second part of your question.
Well, my question is did these ligaments heal? If you hold them in the right space, are they going to heal and provide stability? Or is it like the scapholunate ligament of the hand where you need to do some augmentation? So, you know, that's what I'm kind of getting at is, you know, why you're doing arthrodesis is because you can't get stability. What happens to the Lisfranc ligament or the metatarsal ligament if just left in appropriate alignment? Do they heal?
So I can't quote an exact study, but I remember during the reading that there was some suggestion that if you just let it heal or try to heal, it basically just forms a scar, which doesn't provide enough stability for these primarily ligamentous injuries. So you do have to do something to really bolster the healing enough for it to be stable enough for you to bear weight on it without significant instability.
Brian makes an excellent point, and everybody keeps talking about the pins, the screws, the plates. It doesn't matter whether you use pins, screws, or plates. Brian is right, just like the wrist, because you can hold it anatomically for 3 months with pins, screws, and plates, and for some reason, even if you hold it anatomically, they go on and do poorly, just like with the perilunate dislocations. So I don't know that anyone's done the research on it, but it seems like even though you reduce it anatomically and you hold it and it's there anatomic and you take the pins out, they have pain. So the question is, just like in the wrist, are these ligaments incompetent? And how do you know when the ligament's going to be incompetent? Is it the mechanism of injury? Some way people have to figure that out, because obviously there's two choices here, fusion and internal fixation. But if the ligament's not going to heal correctly, it's nice to know which cases won't it heal. Or is it all the cases? It can't be all the cases, because some people you fix and they wind up doing okay. Do we have any data? Does anybody have any data, or is there any literature on that? I mean, we have plenty on the wrist, and we know that the scapholunate ligament just is incompetent. You reduce it, whether you pin it, screw it, or plate it, it's just incompetent 3 or 4 or 6 months later, which is why 50% of people develop arthritis. But we're not walking on our hands, so people don't need the surgery. Like in the foot, you're walking on your feet and it hurts.
So we don't have the literature on it, but I think there's a couple of things to be made. One, know from the research that's available that ligamentous instability has the worst outcomes. And it's not the ones that are stress positive that kind of look normal, they come apart and stress them. It's usually the multi-directional. So the greater the amount of ligamentous injury, obviously the worse they're going to do. So when you look at ligament injury, soft tissue injury in the foot and ankle, it is our problem. Whether it's a syndesmosis, a Lisfranc, deltoid, lateral, the ligaments simply just don't go back to their original status. And as you know, in the hand, some people make scar tissue that's really stiff, and some people make scar tissue that's really loose. And I don't think we're going to get to the bottom of that. But I think basically your fixation pattern has to match the instability pattern that you see in the time of the OR. So in this patient, she was grossly unstable, and I don't think a 40-year-old would expect the ligaments to go back by that level of stability. And the last point is, we know that if we remove the screws prematurely, even at 3 or 4 months, we get resultant diastasis. So we know that that's not long enough, and I think that's why pins generally don't hold up, because you need to undergo cyclical loading for at least 6 months before you take out the hardware, before you have a stable, ligament structure.
All right, I'm gonna go on to the third case. This was the 18-year-old male lacrosse player who had overall not very exciting AP, oblique, and lateral images, but he had persistent pain. And then he had the stress positive weight bearing films. So we have a little bit of diastasis on stress exam. He's young, he's an athlete. Would anybody fuse him?
How far is he from his injury?
I think this is fairly acute.
Well, I think that's a good point. You said he had presented with pain, like he's 6 weeks out, he couldn't find a play on it, like somebody blew it off in the midfoot sprain. But if you go into the training room, hold the mechanism of injury, it's there 2 days after the injury, saying, my foot really hurt. I think that's a difference.
I think this was like subacute or acute, but it wasn't chronic based off of the notes that I read. I don't know. I didn't have like an exact date of injury though. But it seemed like it had not been going on for very long before he presented to the office.
I would have always said fix it, not use it. So that military study, I have no idea what to do.
Yeah.
Well, that's the point. There's just so many like variations.
This is called Dr. Fleming, say, please fix this person properly. I don't know what to do. I know, that's great. I would have never thought you would use that. I'm surprised. So I'm sure that this injury is what that military paper was all about. I've seen this, my entire career. So I can tell you this person, like I've treated these both even non-operative. I had like a cheerleader who came in, I know it was a Lisfranc Injuries, based on examination. Standing X-ray looked normal. Stress X-ray looked a little bit wide. I said, I'm doing a test for basically not weight bearing 8 weeks. From the cast and went back and cheerleader. So she was vaulting and doing all kinds of things. No trouble with her. See the same exact case in a wrestler who was subacute and kind of whereas a wrestler blew it off like they all do, they're wrestling. And then but couldn't push off. And he inserted that he was fixed. A lot of you that never entered the treatment option. Recovery and that's long recovery. That had to screw out and then went back to wrestling, wrestled pretty well actually. Right. It's interesting that the fusion patients got back faster than the repair. So you say Justin, you want me to one wrong?
Yeah, so I think it's really hard to pitch fusion to 18-year-old. That's really hard to sell. As a parent, I'm not sure that's what I want. Based on study. So, first time injury, I think that you give it the benefit of the doubt. This injury has a lot of stability. This is like kind of subtle injury, you kind of see it in people. So I think this is probably a screw. I would love to bridge like this because I wouldn't want screws across the joint. But I probably wouldn't use it on first.
If you saw the patient like totally acute, offer them non-operative back. What do you think that is about?
I don't think it's good. It's just taking one technology and applying it to a situation. I think that the problem is the bone quality. I think blood subsides and you get 1 or 2 millimeters subsiding to creep that loss of functions.
Get it there.
So, 25-year-old and old right there. Better out.
It's like there's no functional loss.
Will it end up in a final way? So you're gonna use a 25-year-old football player,
It's a great point, and I don't have it in my mind. It's a teenager 7 years apart, so I don't know that I can argue that. I just think 18 a kid in high school is going to have different stresses based on their size and their athleticism. 25-year-old and help on the back that's quicker, heavier, it's going to take a little bit more some flow.
I think that it's also different. It's like a 18-year-old division football player who's just playing fun for a couple years versus someone who's playing for their livelihood.
So I think what you mentioned, Charlie, is just it's a great stuff, and I don't think there's the right or wrong. Just feel substantiate treatment that you're providing. It's not a reason why you're doing it.
But back to your point, I've never treated the non-hour. It's almost like Dr. Kirk about it, where I was pointing out their hand. Regardless of whether that's anatomic, because that the front player is anatomic on a non-standing film. That ligament just doesn't seem adequate.
Exactly. So he ultimately underwent bridge plating. I think, you know, a lot of the literature ends with like the author's opinion or preferred treatment. And I saw a lot of variety in terms of what people wanted to do. Some people used everything regardless of age. Overall, there was a general tendency for like younger patients, though, usually like under 20, to just try to open reduce it if possible. So that's what they did here. And then
There's
he
also
also
just one point I can talk about open reduction.
internal fixation. Sorry, open
Well,
reduction.
no, but as opposed to just like, again, I've seen past cases where they say, well, just put a clamp on it, squeeze it down, just screw it. And I found that, you know, I don't do the case, but I prefer to Dr. Fleming or Dr. Sahadian, they always open it because they say there's just stuff in the way. Just doing it seems like, oh, it's perfect screw. It doesn't seem like that. Very
And these are just his follow-up films 7 months later. Removal hardware.
Yeah.
And I was going to say it's very hard to hear the audience, so I don't know if it's been asked already. But with this case, was the hope that the ligament would heal, and if it's in a subacute period, basically just by holding it in place, and then also during that time that this plate is in, what's his activity restriction?
I'm sorry, within the time that he has this in place, is that what you said?
yes.
No, I said, what's his activity restriction with the plate in? And I assume that the purpose of doing all this is so that the ligament is in correct position to heal.
So I think we kind of touched on that. Basically, we were talking about the key is that you have to open or reduce these, clean out any of the stuff that may be involved in the joint, and then visualize the articular surfaces, and then fix it in place with rigid fixation. And so that I think is why, you know, we hope the ligament heals, but we hope it heals correctly and that the joint itself is congruent and that there's nothing in there to disrupt the intra-articular surfaces. In general, these cases, I think they're usually non-weight bearing for anywhere between like 8 to 12 weeks. And they're normally just like in a cam boot or some sort of like bulky dressing. And then they start to slowly progress their weight bearing with subsequent images just showing like maintained alignment. And then I think he was returned to like full activities once he around like week 12 to 14, even before the removal of hardware took place. But you do wait the full, like Dr. Fleming said earlier, you know, a lot of people, some of the earlier studies were removing hardware at 3 to 4 months. But most people nowadays wait for around the 6-month period at a minimum before they remove any of the hardware.
So you can let him play the season with the plate in and take it out at the end.
I think so, yeah. Because he was weight bearing as tolerated around, I can't remember the exact date, like 10 to 12 weeks. And so as long as he is coming in and you can see that he has maintained alignment and his pain is under control, then I would say that yeah, he should be able to continue playing lacrosse or whatever he was.
And do you have an X-ray, a weight-bearing view 3 months after the plate was removed?
So the right X-ray here, the the weight bearing lateral. This is a weight bearing. I don't think the AP and oblique were.
So what do you think is going to happen 3 months or 6 months after you take the plate out? You fix this 6 weeks after the injury? So you're basically saying fixing an injury in the first few days is the same as fixing this injury 6 weeks later.
And he was fixed acutely.
No, I understand that, but you originally said that this was a subacute injury. You said that the patient had an injury and it got recognized later. And I thought you said 5 or 6 weeks later he had surgery. Was that wrong?
No, I don't think he was fixed 5 to 6 weeks later. I couldn't remember the exact timeline, but it was like either the acute or subacute period, because there wasn't really a date of injury for this guy. But he came in like, fairly, I would say within a couple of weeks of his injury, and he was fixed pretty soon after he came into the office. But it wasn't like a chronic injury at that point.
And I think those films are weight bearing, but you look at the top of your X-ray, you almost see the word bearing.
Yeah, I knew for sure that the lateral one was. I wasn't 100% sure what the AP oblique.
Yes,
But yeah.
they are. So that's 7 months post-op.
So one thing we,
Already played on.
so one thing we want to tell patients is that you're going to break hard. It's going to happen. And so sometimes if you see a screw on the X-ray that can kind of raise the excitement of parents or patients, but these are going to break there.
And then finally, the last case, DT, the 61-year-old lady who had the left foot stress positive Lisfranc injury. She had just a low energy fall from standing with the positive weight bearing X-rays and a little bit of subluxation between the navicular cuneiform and weight bearing. The idea is for this last case on fix or fuse. Use because she's older.
Or I look at that case and say there's somebody. This is an acute subacute.
This is an acute injury.
Yes, I don't know how a 61-year-old does.
A cast.
I mean, that's what we did in the early days, a long time ago. Lisfranc sprain, we didn't move down weight bearing. She's 61 years old, she's probably not high demand. Dr. Fleming has a place.
She's an active golfer. She plays, 100 pounds of golf.
She's a healthy, active 68-year-old lady.
She plays basketball and tennis.
She plays golf.
100 rounds of golf.
100 rounds though, very important.
She would probably do well in a cast. This is the rare case, Charlie. You're laughing, but what do you think? Every single person with a Lisfranc had a horrible result?
I don't think probably not every single person, but I think there's been a high incidence of looking at these longer term studies.
Right. In a 60-year-old person, I'm sure if you looked at just that age group, 60s and 70s, different than the 20s and 30s. The 30s, which is the common age for this. This is not the common age.
Just kind of point out, this is not the typical Lisfranc injury, it's the variance. Someone just point out what they think is unstable. If they were going to ORIF or use either way, what would you address? Sure, that's
cuneiform fracture.
See the medial column line versus the central column. Look at that. Right, see on the next side, left is the side, there will be a column short. So basically, the first metatarsal medial cuneiform fail as a unit, so they disassociate with this franc with near cuneiform ligaments, and the medial cuneiform presses the ligament. This is a little bit different flavor.
That was definitely.
So we heard definite fusion.
Now you pointed that out.
So fusion of the negative cuneiform joint is probably one of the
So she had an open eruption internal fixation. So she basically there, according to the outnote, there was no obvious or visible cartilage damage intraarticularly. The dorsal medial navicular cuneiform joint was reduced and bridge plated to avoid any sort of joint penetration of those screws. And like Dr. Fleming mentioned, basically he had to restore the anatomic length of the medial column in this case. On this last case. So I think, you know, at the end of this discussion, there's just really like a lot of debate. It's a very controversial topic and there's really no definitive correct answer. These injuries are a huge spectrum. And that's what's part of what makes it so difficult to define what the optimal treatment is and to study it to begin with. But if you miss these injuries, it can have really detrimental effects on patient function, which is why there's just a huge emphasis on it, just being able to identify that these patients have these injuries. One thing that is relatively universally agreed upon is that anatomic reduction and rigid fixation are the most important factors for optimal outcomes. And like I said, whatever that optimal treatment is still controversial. Primary arthrodesis may be preferred in cases of extensive articular damage or these purely ligamentous injuries, which was evidenced by a few low-powered studies. And then overall, we just need a lot more information and studies to really be able to assess these injuries. There's a lot of low-powered, low-level of evidence, only a couple high-level of evidence studies. With still just pretty small cohorts. And so it's just still in process. Special thank you to Dr. Fleming for helping me with this. Thank you, everybody. You have to remember to summarize that.
Let's do something until the afternoon.
Or-
Oh, God.